Okay, good morning. First, I also want to thank Diego because I met him, I think, several months ago this year in China. So I also miss him so much. Okay, before my presentation. So today it's my honor to stand here, to stay on this stage, to give my presentation. My presentation title is Multidisciplinary Treatment for Bone and Soft Tissue Augmentation in the aesthetic zone. I'm from China. My name is Yuesa. I'm a prosthodontist, also I'm an implant surgeon. So first I want to share a video. It's beautiful, right? This is the video from my campus, my university. It is called one of the most beautiful campus, most beautiful university in the world. This is from Wuhan University. I like walking to chat with my friend on the street. I like beautiful city, beautiful campus, beautiful world. Like everyone like beautiful things. So aesthetic is very, very important so for everyone. But when we face a challenge in the aesthetic zone, we have to find out where the patient wants to be in this zone. So let's talk about today's patient. The patient came to our office several years ago because he said he has unpleasant, appearance. We can see his face was asymmetrical. And when he smiled, we can see the mouth lifted to one side. And when we check the intraoral examination, we can see the oral hygiene was not so good. We can see the very poor oral hygiene. We can see the missing tooth for tooth 2-1, and also there is insufficient space for tooth 2-1. And also for tooth 2-2, we can see the crossbite. If we zoom in the aesthetic zone, we can see the missing and we can see the crossbite, and also we can see the very crowded indentation for the maxillary and for the mandible. So what should we do? I think this is a complicated case, so we should do the treatment plan. First, we need to do the intraoral, like the oral hygiene extraction, and then we need to do a Prosthodontics treatment to improve the condition, and then we need to do the orthodontic treatment to move the location of the teeth, and then we need to do the implant placement to replace the missing tooth, and then we need to do the prosthetic way to do the prosthetic restoration, and finally we need to keep everything stable. We need to do the review to keep everything was good. So because of limited time, I only have 15 minutes, so I can only show you the key points. First, let's finish the orthodontic treatment. When the orthodontist referred the patient back to my office, and they said, okay, you can start to your implant placement. But we can see actually looks like the tooth 2-1 was a little bit wider than the tooth 1-1. But the orthodontist said we cannot move, we cannot change the position in the anterior region. So we did the detailed design for the patient. We just copy the shape of 1-1 and 2-1 to the contralateral side for the 2-1 and 2-2. We can see there's still a gap between 1-1 and 2-1. That means this was not a perfect result, so we need to change. Maybe 1-1, 2-1, 2-2 together. Then to make it better and make the best way for the patient, and the patient accepts its solution. And we check the condition for the bone volume. We can see there is bone deficiency. We can see there is a horizontal bone defect. And of course, we can see why this is very important and why this is so difficult for the orthodontist to move the adjacent teeth, because there is a large foramen, the incisive foramen between the 1-1 and the 2-2. This is also a challenge for us to do the bone augmentation and do the implant placement. So first, we need to check. We need to do the aesthetic risk assessment for the patient. And we also need to do the SAC classification for the patient. Because of the bone deficiency, because of the aesthetic risk, because of complexity for the kind of case, so we think the patient referred to the SAC classification should be complex one. So what we should do? What we should do? The first one is we need to consider, because of the bone resorption, after the tooth extraction, we can see the bone resorption. If we place the implant with a standard diameter, we can see the exposure for the surface. But can we change our mind? Can we change the diameter of the implants? Can we place the implant with a small diameter, like the narrow size of the diameter? It's safe, it's possible. We check the diameter, we check the reference, and we check the systematic review, and we check the material analysis. And we found that actually, compared with standard diameter of the implant, we can see if we use a narrow diameter implants, because it can be divided into 3 different categories. If we choose the third one, I mean from 3.3 to 3.5, actually it's safe. We can use the narrow diameter implants in the anterior region for the single tooth restoration. It's safe. So we choose the 3.5 diameter of the implants, and also to facilitate the implant placement, we designed digital guide. Then we print everything, we print digital guide. We didn't use the normal resin one, we used the metal one. And then we place the metal one to try the accuracy of the digital guide. And then we start to begin our implant surgery. We open the flap, we see the narrow bone, and then we place the metal guide onto the surface of the teeth. We can see it's very safe. Why? Because it's smaller than the normal one, and it's more stronger, and it's easily for us to see the water cooling, to see the direction, to see the drill. Everything was good. So it's very easy for us to control everything, to control the direction of the drill, to direction of the implant placement. And I said, because of the large incisive foramen, it interferes the placement of the implant. So we just remove the nerve, we just remove the blood vessel, we remove the soft tissue inside the incisive foramen, and then we do preparation for implant placement, like the tension release, it's a bone perforation. And then we did another thing. What did we do? We use the patient own blood to produce the CGF and AFG. What is CGF? This is called concentrated growth factor. This is good. And also we use the AFG. This is autogenous fibrin. Why we use it? Because when we mix these 2 components together with the bone graft, it can be better. It can make the particles into the block bone. We call it a sticky bone. Why it's sticky? Because from SEM observation, this is a sample from my patient. We prepare the sticky bone before surgery, and even after 3 months, I tested this kind of sticky bone. We can see the blood connects all the particles together to make it more stable. This is why we choose a kind of bone graft on the surface of the implants. So we place the implants, we pack the stick bone into the incisive foramen, and then we put just a block onto the surface of the implant. We use a membrane to cover it, and then you use CGF to protect the membrane. Then we suture. Everything was done. Very simple, very stable. And after surgery, we can check from the common CT, we can see the implant was surrounded by the bone graft totally. So what do we do after 6 months? We can see after 6 months, we can check. From the front view, actually, we can see it looks good. But if we check another direction, we can see there's a slightly collapse. There's a little bit collapse. That's because of bone resorption, that's because of the movement of bone graft. That was normal. But what should we do to improve that kind of phenomenon, to improve the outcome for the final one? We can open the flap, we can check everything. When we open the flap, we can see the stable bone graft was already formed. So that means we don't need to improve the condition for the bone. We don't need to do the further bone augmentation, but how to improve it? Further, we can see there is a very thick palatal part for soft tissue in the emplacement for the site. And also we can just change, we can just move the palatal part and insert into the facial part. That was easy, that was minimal invasive. That was very fast. Then we close everything with stable, and when suture with removal, we can see we just increase the count, the soft tissue. And then we have to do the prosthetic way, because I'm an implant surgeon and also I'm a prosthodontist. I need the provision to create the emergent profile for the patients. Then we use a digital impression to get a digital impression for the patient, right? Otherwise, the patient will kill me because of the metal ones. We cannot use the conventional, impression. Then we use the digital impression to design, to deliver the intervention, the provision into patient mouth. We can see the tooth 2-1. We can see compared with tooth 1-1, don't forget it. It's a little bit wider than the tooth 1-1, I mean for the contralateral teeth. If we compare the width between 1-1 and 2-1, we can see we change a little bit, but this was not the best one. So that means even we insert the provision, we cannot create the ideal emergent profile for the final prosthesis. That means we need to do another one. So after we just prepare the 1-1, we just prepare the 2-2, and also we prepare the 2-1. We make another provision and we deliver into the patient mouth. And we can see, use the retainer, we can keep everything stable. The patient was satisfied with the final outcome for the provisions. With this provision, we can create a more accurate and ideal emergent profile and the curve of the gingival and the papilla. And then we copy everything with the intraoral scan to transfer it to the technician, and the technician can make the orthoceramic restorations for my patient. So for the aesthetic zone, we can deliver all the ceramic, the ceramic abutment, the ceramic veneer, ceramic crown into the patient mouth. The patient was satisfied with the final outcome. Even after 3 years, everything was stable. When we recall the patient back to our office, and we check the common CT, we check the X-ray, we check the intraoral view, we can see everything was stable. So the patient was satisfied because we can see there's a big contrast between before and even after 3 years of the treatment. So today, I still have 3 minutes. So today, if you ask me what I should learn from this kind of patient, I will say, when I stay on the stage, I will tell you, if you want to choose this kind of complicated patient, if you want to solve the problem in the aesthetic zone, if you want to solve the complex hardened tissue of the problem in the aesthetic zone, we have to follow the take-home message. First, we need to use the multidisciplinary concept. Then we need to use the digital technique to help us to facilitate everything, to design, to communicate with the patient, to guide your implant placement, to guide your direction, and then maybe we can use a narrow diameter of the implant because it can decrease the failure, it can decrease the risk. Then we can use a steady bone graft like a sticky bone or whatever. Then we can use a connective tissue graft to increase the final outcome of the aesthetic effect. All of them, we need to follow the minimal invasive treatment because we need to treat our patient better, right? So I like my job because I'm a dentist. All of you, I think, are dentists. Why? Because I think dentists, actually, there are 3 different words. We are doctor. We have to treat our patient. We are engineer. We have to build our bone, build the soft tissue. And also, we are the artist. Why? We have to use a smart way to give the patient better life. This is all I want to say. And also, because this is implant competition, right? So implant surgery is one of the most important surgery and one of the most important steps in the whole case. What is implant? Also, for me, is 3 words. Implant 2. Implant 2, we are planning to make the beauty for the patient. This is our aim. This is our destination. So finally, I want to show some of the cases because I wrote 3 books from acquaintance published, but sorry, this is in Chinese. I hope sometime I can translate it into English or into French. And also, welcome to China and welcome to my university. Welcome to one of the most beautiful universities in the world. And this is our hospital. If possible, welcome to China. And this is also one of my channel in China. We call it WeChat. We have more than 50,000 dentists followed this channel. So this is all I want to share because we can share some literatures, we can share some cases from this kind of channel. So thank you once again. Thank you, Mark. Thank you, organization, to give me opportunity to share my presentation. Thank you all. Thank you.